Welcome to you all. Andrea was supposed to be with us. She is unable to, so we apologize for that. But what a great panel. Appreciate you joining us. Daniel, I want to begin with you because you have been instrumental in this report. And just a very general opening question, what surprised you?
Well, you know, there was another report that was done in 2009 by Tom Leviste and Daryl Gaskin at Johns Hopkins University at the time. And they had shown that we had spent within that 3-year or 4-year period that they looked at $300 billion. So we anticipated, right, because that report did not include mental health conditions, right, or mental illnesses, substance use disorders, that perhaps we were going to see something substantial. But what surprised us was how substantial, right? We thought maybe perhaps half of the $300 billion, right? Maybe $150 billion would be allocated to the mental health. But to see it very close, right, to the physical health conditions, the economic burden of the physical health conditions in terms of racial and ethnic health inequities, that was really insightful for us, quite alarming.
And Hannah, we keep talking about these inequities. The federal government has been spending a lot of money on this, and yet the problem is growing. Why?
Because we spent decades not spending money on this, not focusing on this. It's not a problem we can solve overnight. We lack workforce, we lack capacity across the country, we lack cultural competency, and it's going to take time to fix that. The investments that have been made the last few years are unprecedented. We need more, and it's going to take time to see the benefits of those investments.
And Brendan, you have really been on the front lines of all of this in the communities, your work at Bloomberg. What have you seen that has surprised you the most, and where are the solutions?
Well, the first thing that I think is really important to keep in mind is that there's incredibly dedicated, inspirational people who are working on the front lines of these issues. You find them in every community. The problem is that they don't have a system around them to help them support people who are in crisis. We don't have a crisis system. And I often think about this from the perspective of families. We are asking American families in the most difficult times to try to work their way through a system that fundamentally is broken. So I see a lot of really exciting programs, and yet those programs don't scale. And I think that is the fundamental challenge of mental health care and substance use treatment in America, is the models that we know work are not being brought to scale.
But Daniel, it's also an economic challenge. Can you address that? A huge
Sure.
economic challenge.
Huge economic challenge. You know, when I go back, and permit me if I can, to go back a little bit in history, right?
Sure.
You know, for about 165 years, we have struggled in this country to showcase to the country just how important mental health is to systemic health. And Dorothea Dix and other mental health reformers tried in vain, making that moral argument. They went around the country making the case for, you know, how many people with mental illnesses were picked up from the streets, how they were jailed, incarcerated. They were oftentimes stripped naked. They were chained to the walls of these prisons and beaten. It was a horrible time. And even with that picture, we still couldn't get the federal government. It would take, oh, you can't hear me?
I can.
Oh, okay. So
we all want to hear you.
Okay, I got you. Thank you. So it would take then, after that, making the moral argument, it would take about 40 years of her life to finally convince Congress to do the right thing. And they created what we call the Bill for the Benefit of the Indigent Insane. Unfortunately, that bill was vetoed by the president, President Franklin Pierce at the time, who many thought would have been sensitive to this issue of mental illness because he
His
had
own
witnessed-
wife.
His own wife, exactly. His own wife had succumbed to clinical depression and anxiety for the rest of her life after witnessing the tragic death of their son on a train, which was a new invention at the time. Well, after basically vetoing that bill, the president set the federal policy of inaction in mental health issues for almost 100 years. It would take us going through 3 major wars, the Civil War, World War I, World War II, when the country is in this economic crisis, right? This national security crisis, for us to recognize, wait a second, 60% of the hospital beds are being occupied by people with mental illnesses. We're having a hard time recruiting people into the military, 17 to 24. 20% were unfit at the time they deemed. 40% were leaving. We were having a hard time getting folks into the workforce because it was owing to the mental illness at the time, right? And so we can see the impact it's had. And from a political determinants of health standpoint, Steve, We've always had to make the case, tie our mental health efforts, our advocacy efforts, to an economic or national security crisis. It's only until then, when we connect those dots for people in this country, when they recognize, wait a second, this really is a huge issue that's worth investing in.
Brendan, Hannah brought something up about the pandemic, and I'd like to get your take on this and then get your reaction as well, which is, where were we in this crisis before COVID-19, so in January, February of 2020, and where are we today?
Well, we're in a worse place. I think that that's important to say. But pre-COVID, the national data told us that only, less than half of all Americans with mental health problems were making contact with the treatment system. And, if you made contact with the treatment system, sometimes you would be getting quality treatment and sometimes you would not be. So we had these sort of dual problems of access to services and quality of services staring us right in the face before the pandemic. And then what the pandemic has done is it's really ramped up the amount of need in our communities for exactly the reasons that Senator Cassidy spoke about in the first part of today's event, that we have a situation where many people have been isolated, disconnected. A lot of our institutions have not been working. So we have all this pent-up need for services, and we're trying to make it work in a system that just wasn't built for this kind of crisis.
So Hannah, this may or may not be the right word, but is that a silver lining of this pandemic? Are we better aware, better attuned? Is Congress more engaged because of what we collectively have gone through? Because every one of us, in one way or another, has been affected by this pandemic.
We were certainly on the path to having Congress focus on this a lot more prior to the pandemic. There's been a lot more investment in recent years. The pandemic really sped that up. And I think, as you said, what Senator Cassidy talked about earlier is that no one is untouched by mental health and mental illness. We all either experience it ourselves or we know someone in our lives that lives with a mental health condition that may struggle. And so it has normalized it. It has really expedited reducing that stigma. There's still incredible stigma and discrimination around mental illness, though. So we can't say problem solved. We're there. Everyone gets it. But certainly we have sped the process up.
Any one of you can take this next question, because we keep talking about more money, more dollars, the role of the federal government, and I get that, it's important. But I guess what I've been hearing, it's more than just that. It's more than just the federal government. And I'm curious, what is that more? What else has to be done to reduce some of the issues that we've been addressing? Any one of you?
Sure, I'd love to take that. There are so many different levels, right, of inefficiencies and disinvestments. And I think starting for us at the Satcher Health Leadership Institute, when you talk about the workforce isn't reflecting many of these groups that are lacking access to health services. We know that 5% of psychologists, for instance, are African Americans. We need to do a better job diversifying the health workforce. I think the Academy could do a much better job in that realm, making sure that we create more culturally competent mental health professionals would be a great thing. I think also data has been a major issue for us. What we found during the pandemic, and again, going all the way to 1793, was that the same groups of people are always on the downside of advantage and opportunity, or most negatively impacted, right? African Americans, Native Americans, and so forth. And what we thought would be extremely helpful was to figure out how we could get access to data in real time to track these mental health inequities. Well, gee, that was an ambitious undertaking, and we found there is such a dearth of data that we can't even access, right? There's challenges in trying to get data around physical health conditions. It's even worse when you're trying to get mental illness, substance use disorder data, and then, of course, try to track that and disaggregate it by race and ethnicity. So that was a major issue for us, one that we think would be extremely helpful in moving the needle of mental health equity forward. So if we could at least get those two pieces, I think that would be extremely helpful. And then starting also with what we already have, the infrastructure we already have. For us, if you think about it, mental health parity, right? Senator Ted Kennedy and Domenici and Enzi really worked on trying to address the discrimination in mental health benefits. Well, we thought we did a great job in 2008, getting it signed by George W. Bush. And when you look at the implementation of this law, it has been such a frustrating experience at the state level. And we did a study where we graded the states on how well they were doing implemented. Most states got a C, D, or F. I think maybe one state got an A, and I can't even remember which one that is. But they're lacking in that respect. So the states need to really bolster what they're doing in this space. And I think it could start with mental health parity, as well as with integrating primary care and behavioral health services moving forward.
But Hannah, he said something that struck me. My wife is a nurse, and she said that the number one issue she deals with is burnout. Compound that with those mental health providers, supporters who are on the front lines. How do you deal with that? Because it's got to be exhausting. There's got to be a high burnout rate.
There is. We're incredibly concerned about the people who are there to help others. Are we taking care of them? And more often than not, we aren't. And burnout is high. So we're losing more people out of the profession before we're bringing in more. And that's not adding up when we're already in a provider shortage. That mass exodus, which is understandable to a certain extent, is really high. And recently we transitioned to 988, a nationwide number for mental health crises and suicide prevention. Thinking about it there, we don't have enough people to answer the phones, and they're dealing with people on the hardest day of their lives. So anyone who's working in the mental health space, we got to be taking care of them and making sure that we keep them, and really putting wellness programs and the wellness of our providers at the forefront.
Brendan, you're nodding your head.
I totally agree with both of these comments, and I don't want to trivialize the burnout issue because it is so real and so embedded in so many other issues. But one of the antidotes to burnout is seeing recovery. That a lot of times we see people in crisis and then we don't see them being well. And I think that part of what we need to start to sort of move toward is a paradigm of seeing people through their recovery journey. That there is that bad day in someone's life can culminate in some really great opportunities down the line. And I think that the other thing that really sticks out to me about this is that if we want to get people on that recovery journey, then we have to stop taking this as just a medical issue. We have to look at the sort of multiple determinants of recovery. And one of those recoveries is housing. Another one is employment. One of the most effective interventions for people with mental illness is giving them supported employment, giving them a place to live. We can't get people on that recovery journey until we start dealing with the other things in their life that are keeping them back from having success.
So Dan, Brendan offered some very specific, concrete proposals. Moving forward, what would you tell the policymakers? Where can there be meaningful change? What specifically needs to happen? Specifically?
Well, I think the Congresswoman talked about funding first, right? There's been really limited attention paid to this from an authorizing perspective and an appropriations perspective. And I think, we need to do a better job looking at these multiple determinants and drivers of these inequities. I think creating legislation that would tackle this in a more comprehensive and reticulated manner, for instance, the social determinants of mental health inequities, making sure that our agencies, CMS, for instance, as they are tying reimbursement to various health outcomes or value-based care, we know that looking at the course of regulations of policies coming from CMS, for instance, they have really looked at depression primarily, right? And there's so many other mental illnesses, right, that are driving these costs that we've failed to look at. And I know this is coming, from some commercial interests as well, right, who they don't want to tackle those issues. They see it as something that's more difficult and challenging to do. But we have to do it if we're going to move beyond merely nibbling around the edges of the problem of health inequity. So I would say that we need, at that payer level, we need to really include more mental health conditions, substance use disorders. We need to also not make this optional for providers, but we need to ensure that as we are developing these policies and we're tying it to reimbursement, that it's mandatory. For too long, mental health and the health equity piece have been optional, and now is not the time for that.
Hannah, we have been talking about the underserved communities. We've addressed racism. We have addressed incarceration. But there's another huge sector, and those are individuals, the elderly in nursing homes. If you could talk about that.
Yeah, and I think that it's an important topic because that's where we've seen a huge impact of the pandemic. If you talk about loneliness and isolation, elderly adults with that are in a nursing home were separated from families and loved ones for well over a year in many cases. That's a huge challenge. Building a social network, maintaining a social network, we know are a huge factor in protecting and supporting an individual's mental health and well-being. And we need to think about how we build that community and support that community and keep folks connected to their loved ones in that social network at that age.
And your work at Johns Hopkins, what is academia doing? What are we seeing on the front lines from your own prism?
Yeah, so it gives me an opportunity to be a little bit self-reflective, maybe a little self-critical. I think that academics are good at publishing studies and doing high-quality research, but oftentimes our work is not breaking through, or it's not answering the questions that policymakers really need to have at their fingertips. So, I think that we are working hard to add up some of the burdens, so to look at that side of the ledger, the cost, and I think that your study, Daniel, does a great job of digging into some of that, but also kind of really speaking to the needs of models of care that can scale, that can be implemented, and I really think that the future of a lot of our research has to be in what we call implementation science, research that studies how you take models of care and translate them into different populations, different settings. And I love the plug for data. I think that we need better data to answer some of these questions because the academic sphere can be a place where we start coming up with better outcome measurement so that we can drive quality of care and ultimately pay for the services that really help people. But we need quality measures, and I think that academics can be very helpful in that.
Hannah, I really did not intend to get an emotional moment with Senator Cassidy, but I think that showed the raw emotion of the issue. Why is this your passion?
Mental illness has impacted my family. I have struggled with my own mental health over the years. I have seen many of my family members be disconnected from their loved ones, to lose years. We see it too often. And over my time working at NAMI, I get outreach from so many people who want to know how to get help for a loved one or get help for themselves. And too often, it's hard for me to give an answer. I work in this space, and it's hard for me to help them find help. We have to do better. As Dr. Satcher said, there is no health without mental health. Why we isolate this, we think about it as something different, as a failing of your character. We can't do that. That's something that we all need to prioritize, and I've seen personally the impact that has had on too many people, and we can do better. So that's why I'm here.
But in terms of doing better, again, going back to one of the headlines from your report, Dan, if you were to look ahead to 2028 or 2030, how do we bring down those numbers of deaths and the economic impact that we've seen over the last 4 years, from 2016 to 2020 in your study?
That's a really good point. So, and I'm glad you used the 2030 date, because that was the date that researchers in the Lancet had actually identified as the economic burden, global economic burden of mental illnesses escalating from $2.5 trillion around our time right now to about $6 trillion, right? Imagine how much more.
Say those numbers again.
$2.5 trillion worldwide economic burden now to $6 trillion. And that was a study that was published right before COVID struck, right? So imagine how much worse that's going to be. Mm-hmm. So I'm glad you used the 2030 date. Now, the way I look at this, you're absolutely right. How do we bring this down? When we know that the United States is going to become a more racially pluralistic society. We know in 2020, the birth rates, or those children 18 and under, right, of color, now outnumber white children. If they are coming from communities that are sicker and dying younger, right, my goodness, it raises all sorts of economic challenges. So how do we do this? I think it's all of the things that we've talked about today, right, and more. So it is making sure that we are creating those models of care, right? That we are tying reimbursement to this, that we're getting them access to the treatments that they have, that we're actually ensuring the diversity of our clinical trials, quite frankly, because a lot of youth, a lot of people of color have not been included in clinical trials, especially when it comes to mental illness and substance use disorder. So I think if we did that, we could see a whole host of improvements in health outcomes and so forth. And then I also think it's addressing, as I mentioned, in a more comprehensive manner, these social determinants of health. Because what we have found from the literature is that economics, race and ethnicity, and mental illness are all tied together, right? And we know that 13.5% of children and youth of color are unable to access behavioral health services right now. And even when they are able, those 13.5% are able to access it, it's of lower quality. So I do think from all levels, from the models all the way up to the upstream determinants of health, if we address that, and we addressed it in a meaningful manner, we would see those numbers improve. And the United States would what? Actually be able to attain its position among the healthiest nations in the world.
But Brendan, I never thought we'd have a conversation about Franklin Pierce and mental health, but if you go to his house in New Hampshire, and I've been there, they talk about the mental health issues that his wife faces. Why do I bring that up? The historic disparities when it comes to dealing with these issues, and to kind of break through what Hannah was talking about. How do we break that cycle? What are you seeing on the front lines?
Well, this is the oldest problem of our country. This is a problem that is not new to anyone, and I think that what we have to do is start to see what's plainly in front of us, the problem of mental illness that affects all of us in our communities, and we have to start. I think that the numbers that we've been hearing today are so staggering, they almost feel paralyzing. Mm-hmm. It's like it is a burden, but we don't have to live like this. There's a better path forward, and I think that part of it is, as a researcher, I believe research can change hearts and minds, but we have to also kind of commit together that this is not acceptable anymore, because we've gone through several years of just tolerating hundreds of thousands of Americans dying from these problems. Drug overdose, suicide. The numbers just are numbing now. Yeah. We have to say it's not acceptable anymore, and to start treating it like the problem it is.
But Hannah, as you know, we are in Washington, D.C. This is a very political town, and we heard from the Congresswoman. We may have a divided government next year. We don't know what's going to happen in the midterm elections. We know that every 4 years we elect a president. We may have a Republican president down the road. How do we make this a non-political issue? How do you address this debate in a partisan environment?
Fortunately, this has largely been a bipartisan issue. When we look at packages that are moving through the House and the Senate right now, they are bipartisan mental health packages that we are hopeful will move before the end of the year. Just today, Ways and Means is marking up a package of bills that are about behavioral health care and improving access to behavioral health care. And again, done in a bipartisan way. I think how to pay for it is often what differs, but there is commitment that this needs to be addressed, and we are talking to offices on both sides of the aisle and see that commitment. I think it's incumbent on advocates like NAMI to continue to bring those stories forward and make sure that lived experience is at the forefront. We always say nothing about us without us, and I think that's absolutely critical to make sure that these policymakers keep hearing from their constituents and keep hearing about the real life impact in their districts.
Our partners in this, OTSCA, what is their responsibility? What is their role, Daniel?
What is your role, OTSCA? Well, let me just first thank OTSCA for investing in this study, because for me, this is a 15-year dream come true. For 15 years, I had tried to get either NIH or get a foundation or get someone to fund it, but nobody really cared about the issue until, of course, I met Deborah and I met her team, and we talked about the mental health inequities that were plaguing what we were seeing during the pandemic, and we created our health equity tracker. We were tracking certain things. So as we were looking at these numbers and looking at the figures from this time period, it was extremely frightening for us. So OTSCA really stepped up and gave us this ability, provided this tangible evidence, if you will, right, through our research, documenting decades of systemic health inequities in America and the impact it's having on communities of color in particular. So I think they've done their job, first of all. They are thought leaders, they're leaders in this space. And in moving forward, I know Deborah and I talked about this, there's so much more to do, right? You talked about more research. I am a firm believer that research, especially external research, has helped us to ensure that we create and we implement mental health equity focused policies. And so I believe that OTSCA has been critical in helping us now for the first time to really create a policy that will address this pretty comprehensively. So they're doing their job. I want to see more, of course, coming out from not only them, but of course the other commercial interests that play in this healthcare space.
Let me build off that and give each of you a chance with a final comment. How do we get there? What obstacles are you concerned about, and how do we reach the goal that Daniel talked about in 2030 and beyond? And Brendan, we'll begin with you.
So I talked about sort of the point of moving hearts and minds, but a lot of the way that we get there is through fairly kind of difficult, roll up our sleeves, let's try to figure out models of care that work and work on scaling them up. This issue of scale is the thing that I'm really passionate about, because we can start to change outcomes if we start paying for and identifying the models that will help people.
And scale holistically.
Scale holistically in every sense of the word, available to everyone in every setting, available if you're coming out of prison, if you're in a school, if you're just living in your home and you seem to be very productive, but there are things that are bothering you. So scale across the population, scale across sectors, scale so that it really reaches anyone who could benefit from mental health care.
Hannah, we'll give you the final word.
I couldn't agree more. Too often we have seen exceptional models that offer so much promise, and they just fall short because we don't invest in them. We don't make them available to everyone. So there's incredible promise that's out there. And one thing that gives me hope, and talking a little bit about hope for the future, we have a younger generation that is much more willing to talk about mental health. And I think if we focus investments there, particularly since we have a youth mental health crisis, of addressing suicide prevention and early intervention, we know that works. We know that can have an impact. Too often we wait until people are at the point of crisis to intervene. We can do so much more for so many more people if we are intervening early, we are providing more resources, and we're starting at a young age.
You were nodding your head. Do you want to close this out?
Well, thank you so much. I appreciate it. So I was nodding because I was thinking, what also gives me hope is that, by my count, we are in the fourth period of a great awakening for health equity in this country. And, this started from Abraham Lincoln's tenure to the civil rights movement, then to the late 1970s, when our country was really looking at the more subtle forms of discrimination in mental health and healthcare as a whole. And now we're in this fourth period where we now have a government that is committed to health equity, to addressing the upstream determinants, and I think this is such an incredible opportunity for us to leverage the moment and to move these policies forward. So that's what gives me hope. So thank you for the
Well, you come to the table from very interesting perspectives. So Daniel, Hannah, Brendan, thank you very much for participating, and our thanks to thehill.com and to all of you for watching, for listening, for learning, and hopefully for enlightening all of us, including myself, on what is an issue that we need to address much more. Thank you.
Thank you.
Thank you, Steve.